All right, welcome everyone. I think we're going to get started. Yeah. So for those of you who don't know me, although I think I do know most of you in the room, I'm Catherine Sorsdahl, and on behalf of Ashraf Kaji and I, the co-directors of the Alan J. the Alan J. Flisher Center for Public Mental Health, we want to welcome you to the memorial lecture. So this lecture does take place every year, and it's really to celebrate the life and the contributions of Alan, who is really a pioneer in public mental health. And this year, we have a really nice video. It's going to be Atale Alam from Ethiopia, who is both a friend and colleague of Alan, to say a few words.
Dear Melorisa, Adam and Kailila and colleagues, I would like to say a few words about Alan on this occasion where we celebrate his life and his work. I came to know about Alan through his work in the 90s. When I was doing literature search on African community-based mental health studies, I found few articles authored by Alan, and I benefited from them because I was doing my PhD in those days. Some years later, Alan and I met at different global scientific meetings and became good friends after that. I also came to know more about Alan through testimonies I received from Ethiopian psychiatrists who were trained by Alan and Brian Robertson in the Department of Psychiatry at the University of Cape Town. While we were preparing to do more collaborative work with Alan, suddenly and sadly and untimely, Alan passed away, and that was a great shock to me as it was to all of you there. Although we lost Alan at that time, because of a good team and the good legacy he left behind, our collaboration between the departments of psychiatry at Addis Ababa University and University of Cape Town continued, and we were able to do good scientific work in collaboration and also capacity building in different people who are engaged in community mental health work.
Okay, so everyone on Teams just got to hear that wonderful lecture from, or introduction from Atale. For those of you in the room, I am going to send the video to all of you so you can see it. It really was a wonderful way to introduce Alan and to have the many contributions that he gave. And I know Mira, Nisa, and the family are online today, so they did get to hear it. So I will send through to everyone. Apologies for that. So at the moment, I'd like to introduce you to our talk today. We have Charlotte Hanlon, and Charlotte is a psychiatrist and mental health researcher who lives in Ethiopia. The main focus on her work is on developing, testing, and implementing interventions that seek to improve the lives of people with mental health conditions in low middle income countries. She has a particular interest in working with people affected by severe mental disorders, including psychosis and developmental disabilities. And as you would have seen from the invitation that you all got and was distributed, Charlotte leads several internationally funded grants, such as HOPE, an NIHR Global Health Research Group on homelessness and severe mental illness, and many others. And she is also a commissioner on the Lancet Commission on Psychosis in the global context. So over to you, Charlotte.
Great. Thanks very much indeed. It's really lovely to be here amongst you all. And an honour to be able to speak to you about the work we're doing in Ethiopia. So sadly, I was never able to work with Alan, but he did make a big impression on me. I went to a meeting in Kenya, and I remember him presenting about a school-based intervention that he was doing. And he was quite upset and sort of complaining, not really, well, he was sort of complaining really about the authorities who were wanting to scale up this intervention, even though he had not produced enough evidence to justify the resource being put in. So that made quite a big impression. And I thought, yeah, this is a man of great integrity. And I should listen to this. And I might come back to that just at the end. So I'm going to speak about this idea of the goal of all the work we really do in Ethiopia is about this sort of restoring the person's life and what that might mean and what we might do to try and achieve it. And I'm talking about severe mental health conditions today and referring to psychoses, for example, schizophrenia, bipolar disorder, and severe affective disorders like depression as well. So just to remind you, so Ethiopia is in the Horn of Africa, and I don't need to say that with this audience, but and it's the second most populous country on the continent. And you can see it's a young country, it's quite ethnically diverse. Unfortunately, that's part of the reason that we're in the news at the moment, but it's also part of the reason that there's a very rich cultural heritage within Ethiopia. It's very rural and still struggling with quite a lot of issues around poverty. There was some progress being made, a little bit set back with the recent conflicts. So I've been living in Ethiopia for 15 years now, but I'm not the only person who thinks it's a special place. So a famous person from South Africa also talked about the special feeling about visiting Ethiopia and what it meant, going to visit the origin of humankind. And I would sometimes, at this point, show a picture of Obama looking at the skeleton of Lucy in the National Museum. So you have to come and visit. So this is the quote, the full quote that gave rise to the title. And this came about during the formative phase of the PRIME project, when we were thinking about how to develop and expand mental health care in a district. And so the quote is, "The process of restoring the person's life will be a time-taking process, as this is a person who's lost many things in the course of his illness." So I'm going to sort of take you on a bit of a journey about how far we've managed to come to trying to sort of achieve interventions that might help to do some of this restoration of the person's life. We've certainly not reached the destination, but there's a lot of hope on the way. And as I'm speaking, you'll see at the beginning, there's not so much involvement of people with lived experience, but you will hear their voices coming as we go through the presentation. Now, to treat this a bit like a theory of change workshop, we're starting with the outcome, but what does that mean? What is it that we're trying to seek to change? And we have this data set of 57 interviews from the RISE trial, which was community-based rehabilitation, and they were exploring what recovery or what getting well meant to people with severe mental health conditions in a rural setting in Ethiopia. So this is the thematic analysis. So the first really key component is around being able to work. And that was really in the service of being able to have some form of economic recovery and have a standard of living that allowed people to live with dignity and achieve their basic needs. And then the next three sort of domains that people spoke about are interlinked, related to social functioning, and also very much mutually dependent on their economic recovery as well. So social inclusion, being treated just like anybody else within the community, being able to fulfill adult roles, so within the family in particular, and then being able to fulfill socially important roles in the broader community as well. So these were the overwhelming things that people spoke about. People also mentioned being mentally free, not in terms of psychotic symptoms specifically, but a feeling of being free of stress and having to think too much, which again somewhat interfaces with economic recovery. And then this sort of notion of just wanting to be back to normal and being able to live just as well as everybody else. So this is the sort of starting point, and now I'm going to take you through some of the work we've been doing. But before I do that, I can't speak about severe mental health conditions in Ethiopia without talking about my wonderful colleagues who did groundbreaking work that really is the foundation of what we've been doing. So there's, from left to right, you've got Professor Atlai Allen, Professor Dereji Kepbada, Dr. Dashoma Shibre, Dr. Girmay Medhin, and Professor Ababal Fikadu. And what they did was a really astounding epidemiological study. They screened a population of around 68,000 people with active case detection, and then did high-quality diagnostic interviews using the scan, so rigorous sort of mental health diagnostic interviews, and identified 919 people from this population that was then followed up for 10 years. So there was some monthly clinical assessments and then sort of more regular annual kind of more in-depth assessments. And this led to many important findings that form the basis for our work. So first of all, there was a very high treatment gap. Only 10% of people had had any contact with care. And contrary to findings from like the WHO multi-country studies of supposed better outcomes in low and middle income countries, there was low level of remission and people had poor functioning and capacity to work. High mortality, 2 to 3 times increased compared to the population. Poor health, undernutrition was more common. High levels of stigma against the person and their family, and distributed impacts across the family and intergenerational impacts. So that's really our starting point for thinking about restoring a person's life. And now I'm going to take you through a life of logos. So these are 4 projects that really have been trying to, I'm going to talk to you about what has been achieved by these projects in relation to those desired domains of recovery. And each of these projects has been somehow linked to the World Health Organization Mental Health Gap Action Programme. Here's the picture of the intervention guide. And I'm sure most people on the call and in the room will know what this is all about. But when it comes to people with severe mental health conditions, the premise is that general health workers will be trained to deliver a supposedly circumscribed group of tasks. But when you look at this list, it's not very circumscribed. This is asking a lot of general health workers. And in the Ethiopian setting, this is health officers and nurses. It's not generally doctors in the rural areas. So we're expecting people to make a diagnosis, to consider the physical health of the person and rule out physical causes, assess risk, consider prescribing, starting prescribing, informing the person and their family, supporting them to reduce stress, expand their social networks, rehabilitate them, follow them up, and know when to refer. So this is a lot to ask. And so although the idea of having parity between mental health and physical health through integration in general health services is a bit of a no-brainer. I mean, why would we argue against that? But the question is really more, how can we achieve it? So in Prime, the idea was what we were trying to do was see how the MH gap intervention was how it could be implemented within a whole kind of integrated district level mental health care plan, developed, implemented and scaled up. So here are the 3 characters involved in leading that. So Professor Crickland, Professor Mark Tomlinson and Professor Vikram Patel. And then I'm presenting on the Ethiopia data, and Ethiopia lead was Professor Ababal Fikadu. And then the Emerald project was sort of linked around Prime and was really around, well, what are the system supports that you need alongside these packages, this integrated plan to make it work? And Professor Sir Graham Thornycroft led that work. So this is our sort of summary diagram, which many of you have seen before from Prime. And the first point to notice is that the MH gap intervention guide is just a tiny component of all of the packages that are required to make this work. And you've got community level packages, which are about proactive case detection, reducing stigma, trying to support people to be included within the community. Then you've got at the primary healthcare level, not just training clinicians, but also anybody who's sort of front-facing to reduce stigma and facilitate people's coordinated care, and be able to manage a continuing care kind of model. Specialists, so in our case in Ethiopia would be psychiatric nurses, have to be sort of retrained, reprogrammed to provide supervision and support, consultation on difficult cases. And then at the healthcare organisation level or health system, it was necessary to put in some capacity building around program management, setting up a revolving drug fund so the medication would be available, setting up information systems so we could have monitoring and evaluation, establishing ways to have multi-sectoral links, and all of these things needed to happen for the whole program to work. So this is what was being implemented, just to give you a sense. And now, one of the evaluation components of PRIME was to look at that in terms of an intervention cohort. So in the Ethiopian setting, we had a district which was about 100 kilometers south of Addis Ababa, a population of 180,000 people. And through proactive case detection, we identified 369 people who had a probable severe mental health condition. And 300 of they were all referred to the primary care setting where the health workers had been trained in MHGAP, and 300 people attended, so that's around 81% contact coverage. And we also evaluated, there was a confirmatory diagnostic interview because we might have concerns about people making a diagnosis of a severe mental health condition and what happens when people get that label. So we found that 95% of the people diagnosed with having a severe mental health condition were correctly diagnosed according to the psychiatric nurses using OPCRIT, and there was no evidence of dangerous prescribing, also a big concern from the government and from other people as well. We followed people up for 12 months, and for the research assessment, we got follow-up of about 81%. And for the clinical component, you can see that engagement with care over the 12-month period was not optimal. So it was about 30% what we call minimally adequate treatment, which means at least 4 contacts with some sort of level of therapeutic intervention, whether that's medication or something else. Now, during that time, so only 30%, during that time, people were not particularly either going to traditional or faith healing. That was only about 13%. And we also had a control cohort that was the general population to look at economic interventions as well. And in the PRIME sample, the people who we were engaging in care, it was predominantly people with primary psychotic illness, schizophrenia, and only 14% had bipolar disorder or depression with psychosis. And that's partly because we were looking for people who had an immediate and ongoing need for care. So people with more episodic illness were not really being adequately captured. More men than women. You can see only less than half, fewer than half, had any kind of formal education, which represents really the population in that area. And we may have ideas that there's always lots of, social support and social capital, but actually 30% of people and their families reported low social support. And you can see that people were quite unwell at the time of coming to care, so relatively high levels of symptom severity and functional impairment. In the district where we were working, when we started to engage them, work with the Community Advisory Board, they told us alcohol was a big problem, and we found 30% of the people with severe mental health conditions also had problematic alcohol use as well. And then 14% had reported attempting suicide in the previous 3 months. So just to emphasize, this is a fairly complicated and unwell group that was coming into the system and receiving the treatment at the health centre level. So now I'm going to tell you some of the impacts. So the first one is, I've got 3 slides that are about economic impacts, just to reflect the importance as well. So in this slide, what you can see is on the left-hand side, it's out-of-pocket costs. So this is money spent by the families looking for treatments and anything to help. And that includes traditional and religious interventions. So on the left-hand side is baseline, the blue, and the red is the 12-month follow-up. So you can see the costs to the people accessing care, even though they had many more contacts with mental health care than at baseline, it was costing them much, much less. So there's a substantial reduction in out-of-pocket costs. And on the right-hand side, you can see the cost to the health service, and you can see that, as we would expect with a task-sharing model, we expect it to be more efficient within the health system, and that there was a reduction in the cost to the health system at the same time as reaching many more people. So most of the reduction in the out-of-pocket costs was because of reduced help seeking from traditional and religious healers. And I just also note, though, and something, this is really about inclusion, community-based health insurance was being rolled out across the district and was expected to have an impact on out-of-pocket costs. But you can see the households of a person with a severe mental health condition were less than half as likely to be able to access that. And we found that those who did, that was strongly associated with smaller out-of-pocket costs, as you would expect. Severe food insecurity was experienced by 30% of the households of people with member with a severe mental health condition at baseline on the left-hand side, compared to 13–14% in the general population. And you can see that that also improved. The left-hand side is the baseline, the right-hand side is the 12-month follow-up. You can see that also improved and came a long way towards the level in the general population, although still is actually about 50% more. And there were other economic impacts as well. This is income, household income. So this was significantly improved over time relative to income change within the general population. You can see, hopefully on the left-hand side at baseline, households of a person with severe mental health condition had lower household income, and that came almost up to the level of the general population. And just to remind you, there were no economic interventions at all. This is just increasing access to mental health care within the healthcare facility and social inclusion. So one of our PhD students, Kabeda Tefisa, who was on the previous slide, his work tried to understand some of the mechanisms, and reduced discrimination and stigma seemed to be the biggest mediator towards improved economic functioning. However, there was no impact on the capacity of the family to spend money, so their increased income was being used to probably offset expenditures that they'd incurred. And they didn't regain the number of assets, and they had many fewer assets at baseline compared to general population. Other key outcomes, so we saw improved functioning, a moderate sort of effect size, a much smaller effect size in terms of symptom severity improvement. So again, perhaps these functional improvements are coming through sort of more related to inclusion rather than actual clinical improvements. People reported reduced discrimination that was significantly improved, and also important impacts on human rights, so less likely to have been restrained. And you will notice in the slide that at baseline, in the 12 months before being recruited, 25% of people have been restrained within their home. For various reasons, but mostly because of the lack of alternative. That reduced to 11% by the 12-month follow-up. Suicide attempts were reduced by a third, and you can see problem alcohol use also reduced. And this is a quote from one of the community health extension workers who speaks about what this seeing people improve and being more visible within the community, what it did to community attitudes and how that kind of improved what the community was willing to do. So they see people are now leading their lives and joining the community in different social occasions, and it gives them a good attitude. And this quote talks about how that led to much more community mobilization. So this is talking about a person who was homeless, very visibly unwell, and improved with mostly just medication. But was also supported a lot by the community to the extent of paying rent and supporting him to find his feet. So that's one model, and I've shown you some of the impacts that Prime appears to have had. Now that was a pre-post non-controlled intervention study. We didn't have a control group because usual care would have really been no care. And so that was felt to be unethical. So But of course, partly you might say, well, would people have improved, would things have improved without intervention? So for the economic component, we had a control that was the general population to control for secular trends, things happening within the population. But we didn't have a control group of people who weren't receiving prime but had a severe mental health condition. In the Affirm Tasks trial, we were able to do a randomized controlled trial, and that was because we had this unique sample that arose from that Buttigieg epidemiological study I introduced you to at the beginning. So when my colleagues in Ethiopia started to do that epidemiological study, they actually, alongside it, they established a service, which was psychiatric nurse outpatient care in the local hospital. So it's centralised and it's quite a big geographical area, but it was most people were accessing that with support of the project. So this is unusual because if you normally get to where people are accessing mental health care, it's normally an extremely selected population. You know, much tend to be socioeconomically better off, more educated, and not at all representative of the full population of people with severe mental health conditions. So this was an opportunity. And what we did in tasks was we randomized people, and I'll show you actually in the next slide. Or first of all, just to say here the three co-PIs for this trial. Again, Crick, Professor Asla you've met, and Professor Ezra Sissa. And at this point, you might be thinking there are a lot of men in Charlotte's life, but there will be more women in my life coming soon. So what did we do in tasks? We were asking a different question. We were saying, is the care that is delivered in primary care through the MHCAP model, is it inferior or non-inferior to the existing model of care, which is scaled up across Ethiopia? And is the majority of people with severe mental health conditions in Ethiopia would access that kind of model of care, if at all. So we randomized the people who were in that accessing psychiatric nurse care from this representative study to either continue with that care or to be referred back to the health centre. And then we followed up for 18 months, and you can see we've got very high levels of follow-up, over 90%. Just to compare the models, basically. So prime, we're asking the health workers we're going out into the community, finding people with untreated illness who are quite unwell, and the health workers doing the whole thing, the diagnosis, the initiation of treatment. In the tasks trial, they've already had some contact with a mental health professional who has made a diagnosis, initiated care, they've been stabilised, and then they're coming back. And the role of the healthcare worker in that setting, in this trial, is then to maintain the gains. And as with Prime, we had a very participatory process of developing the intervention, and we ended up training 112 health centre nurses and health officers in MHCAP with an add-on clinical direct sort of on-the-job training. We trained pharmacists within the health centres on safe dispensing because they weren't used to dealing with psychotropic medications. 100 community workers to do outreach. So if somebody missed their appointment by more than 4 weeks, a community worker would visit their home and encourage them to attend. And then the psych nurses had a similar kind of orientation to a new role in supervision and consultation. And the people accessing this service, so this is in the neighbouring district to Prime, it's completely sort of separate actually. You can see that there are many more people with affective disorders, so it's about half-half. In this trial, we argued that it was important to include people who lacked capacity to consent because of a principle of equity, that this was a service that was endorsed by the Ministry of Health, was being scaled up across the country, and we needed to know whether it was going to benefit everybody. Similar to the other samples in terms of literacy and gender, we measured body mass index, and 23% were underweight at baseline. When we think about sort of nutrition and physical health and the associations with mortality in people with severe mental health conditions, it's very much dominated by studies done in the West, where there's much more concern with people being overweight. And all of the recommendations around reducing premature mortality are around those kind of sorts of interventions, but not at all relevant to this setting. And it's a neighbouring district, but it's a different religion, predominantly Muslim, and there's very limited issues with alcohol, but 4% use chat. Chat is an amphetamine-like stimulant. Just sort of shows why localised planning is important when you're developing mental health care. So this is our beautiful primary outcome, and I'll just take you through this slide. For a non-inferiority trial, what you have to convince people is that the people receiving the new intervention are somehow non-inferior to the existing intervention. And there's a margin of error that you can have around that. So we argued that anything up to a 6-point difference on the BPRSE, which is a measure of symptom severity, would be okay. That would be, if there was inferiority, it would not be clinically significant. And you can see the dotted line is that margin at 6 points. But actually what we found is that it was almost zero. It was less than 1 point difference between the intervention arm, the task shared model, and the existing model of care. So non-inferior is what we found on the basis of symptom severity. And then when we look at the secondary outcomes that were patient-reported or caregiver-reported, they were also non-inferior, all of them. So with respect to functioning, relapse, satisfaction with the service, self-stigma, side effects of medication, and body mass index, there was no inferiority of the task shared care. Now, we had hoped that help-seeking costs might actually be lower, but we didn't see that. And it's possibly because we ended up paying some of the healthcare costs for the hospital arm of this trial. And that was mandated really by the Community Advisory Board, who said nobody would want to be randomized to the more centralized care, which in a way was already a finding of the trial, that people really wanted care to be close to home in a primary care setting rather than travelling a long way to a centralised facility. And that was already against the expectations of our funder, who was really worried that people would prefer to go further for quality care or the perception of quality care. We also looked at caregiver burden and caregiver outcomes, and these were also non-inferior, so no increased stigma with this model. There was some concern about having treatment closer to home potentially could increase stigma. That wasn't seen. And again, we hoped for reduction of time burden and lost productivity costs, but we didn't see that. But it was no worse than in the hospital psych nurse arm. We also looked at sort of the patterns of engagement, and there was more tendency in the task shared arm for people to miss an appointment by more than 4 weeks. But because we had the community workers doing an outreach, they still received more than, I think it was a mean of 8 visits over the 12-month follow-up compared to what we saw in PRIME. So the minimally adequate treatment for the tasks trial with that simple addition of the community worker was now 80% rather than 30%. However, people were not more likely to disengage more often, so it was just more intermittent. And actually there was a superiority effect of the task shared care. So we found that physical healthcare referrals and investigations were more likely in the health centre. And we actually did predict that. We said that there could potentially be more integrated holistic care rather than in a sort of specialist vertical clinic. We found no evidence of inferior quality of care. We did extensive notes reviews and looked at what was documented, and no difference in serious adverse events. And then we also found the trial to be, the task shared model to be cost effective, and with a willingness to pay threshold. This is what this graph is showing, that there's a good probability that it's cost effective. So a different model of using MHGAP, but also developing, expanding access and also improving a range of outcomes for people. But we also had this concern about, well, what about the people who don't do so well just with this kind of very basic intervention? And Laura Asher, pictured here, ran trial of community-based rehabilitation that was added on to the PRIME model. So it's a nested study. And so anybody who'd not responded to the PRIME, in the PRIME district, anyone with psychosis who had either not engaged or who'd not responded was enrolled in this trial. So it's a cluster RCT at 168 people, and they either had PRIME plus CBR in their sort of health post vicinity, or they just had the PRIME intervention. And they were followed up for 12 months, and again we had high levels of follow-up, which is good, especially for this. This was a non-engaging kind of subgroup of our original study. So CBR intervention was developed again with a very participatory kind of approach, and was a 12-month program, more intensive at the beginning, kind of spacing out home visits towards the end. It was delivered by completely a sort of parallel cadre of workers. They weren't in the health system. They didn't have any health training. They were just people who lived in the community and had an aptitude. And some people, there were some core elements that everybody got, like psychoeducation, and then there were some modules that were more tailored, for example, around social skills or family relationships or livelihoods. This one was predominantly, it was all primary psychosis, and 82% had a diagnosis of schizophrenia. Again, poor social support, relatively high alcohol use problems, and at the bottom you can see, again, this was a more unwell group. And here's the overview of the findings, which were published this year in Lancet Global Health. So the primary outcome was caregiver-rated functioning, and that significantly improved, as did a global assessment of clinical status, and medication adherence improved, and so did engagement in care. And there were some impacts on caregiver components of caregiving, especially worry and tension. However, there were quite a few things that were not improved. So self-rated functioning, using the same scale, but rated by the caregiver or the person, about the person who had severe mental health condition. There's a discrepancy. Symptom severity didn't improve, relapse didn't improve. People were no less likely to be restrained or to report discrimination. And in fact, and we don't really understand why, they were actually less likely in the intervention arm to be employed at the follow-up time. And there were also minimal impacts on caregiver mental health and the amount of time and supervision that they needed to be involved in the person's care. So let's go back to those valued outcomes that we had at the beginning. Slightly expanded, I've added physical health and family at the bottom as well. And just sort of take stock about, well, what have these studies shown us so far? So Emerald and Prime showed us that there can be impacts on work and economic recovery, social inclusion, social roles, and to a lesser extent, clinical improvements and family impacts. In Affirm, again, physical health, potentially positive, mental health as good as the existing care model. In the RISE trial, social inclusion, social roles, to some extent improvement in symptoms, and to some extent family impacts. So some impacts, but some inadequacy of impact as well, if we're thinking about our goal of restoring the person's life. So what are the key kind of issues? So in the work sort of economic domain, as we said, people still had fewer assets, and sort of this is kind of part of keeping people in a recurring cycle of poverty. They sold their assets at the beginning to seek help, and even though their income may stabilize, they may not have enough income to regain their assets. And so work capacity was not fully restored by any means. You will have noticed from the figures that a high proportion of people were still experiencing being restrained in the community. And perhaps I should say that very, very few people in the follow-up accessed any kind of specialist mental health care, and almost none were admitted to hospital. So in a sense, what this is people who would probably need inpatient care and have ended up being restrained at home. And then, as we said, in terms of inclusion, there was an issue around the community-based health insurance. In terms of sort of adult roles within the family, we didn't really look at that. That's a longer term outcome, so we can't say there's been any impact there. And although there were improvements in social roles, it was undermined by this lack of kind of full economic recovery. In terms of this concept of sort of full recovery and being like everyone else, which is not purely clinical, but what I wanted to mention here is that, of course, we have very limited choice of antipsychotic medication and very little sort of second line. So if people don't respond, then what? So not everybody is responding. And we didn't see, great improvements in clinical symptoms. Maybe that doesn't matter if people are functional. We also saw long durations of untreated psychosis, a median of 5 years at intake into the Buttigieg study and also into PRIME. And physical health, high mortality in PRIME, 11 people out of the 300 died during the follow-up period, and there was no impact on nutrition. And limited impact on family mental health. So there's still a lot that's not been captured. So taking a step back, one of the things we thought would be really important all the way along was more increased involvement of people with lived experience in sort of developing services and having contributions to what should be in services to make them comprehensive and meet their needs. But we started with the Emerald Project. We did a qualitative study and we asked people what they wanted and what they felt would help them better. And it was very difficult to engage people in these kind of discussions, and they would very often say, you're the experts, don't ask us, we don't know anything, and really sort of reflecting a long-standing sort of marginalization and exclusion from these processes. And so we started this quite long process of thinking about how we could strengthen the voices of people with lived experience with a view to sort of thinking about these other aspects of the inadequacy of the models. So we built on some of the work from TPO Nepal, adapting a training workshop called Empowerment, but really being about sort of trying to increase people's expectations of care. So they were very, very satisfied with extremely minimal care. And we really wanted to increase their dissatisfaction, actually, so that people had higher expectations and were perhaps willing to hold people to account for those, and to kind of help people to understand more about the mental health condition that was affecting them, the kind of treatments and the things that they might be able to do self-management wise. So there was very low level of awareness at baseline. And then alongside that, and linked to the Opal project, Seaside Abina, you can see him here, looks as if he's conducting an orchestra, but it's actually, this is a part of a photo voice session. So all of the people, we had a group of around, I think it was 16 people with lived experience and caregivers, and they had disposable cameras, and they were supported over a period of 8 weeks to go out and take photographs that helped to capture their recovery journey and important messages, things that they wanted to convey. And then they were supported to develop a way of presenting that and given the confidence and the skills to do that in a public setting. And Seaside also nested some participatory action research, so then worked with this group to start setting sort of action plans about what they wanted to do next and what important things that should be evaluated as part of that. Written this up, and there were lots of very interesting things. I'm just going to pick out 3 of the kind of themes that I noted. So the first one was really that it's very boring to be in a research project normally, and that people were very positive about being much more actively engaged in the process, and sort of saying that it's a really different experience and they liked it. And the second was perhaps some of the benefits that can help us, again, restoring the person's life, thinking about when people were collectively brought together, they actually organised and developed a service user association within this district, and you can see in this quote they're talking about saving together and trying to overcome some of those inclusion issues, but also to support one another. And then perhaps I think what comes out most strongly from the evaluation is that people were very happy to be valued and for their lives and their voices to be given some worth. and lots of very distressing quotes really about how people have felt very isolated and neglected and bored sitting at home, and that this gave them some enjoyment but also some value, felt it was valued within the group but also within the community. So we've been sort of thinking about how to develop that further in our work. Here's a shout out to Local Girl. Where are you, Carrie? So again, we're getting into the female co-PIs here. So Laura, Asha and Carrie are leading this very interesting trial, feasibility trial within South Africa, developing, using, so what could be the contribution of people with lived experience, and this is setting up peer-led recovery groups in the context of a mental health service. So linked to people accessing kind of care within the primary care setting, to see whether it improves people's inclusion and other outcomes. And we have a new project called Scope, which is funded by the Wellcome Trust. And we are also in this project trying to sort of understand how to overcome some of those gaps. So again, well, we have Eleni is the Service User Association president in Ethiopia, and she's actually leading on, we've got a sort of add-on grant for Scope, which is about developing social contact interventions to reduce stigma for key people, and Tessa Roberts worked with us to get that grant. So for example, targeting the police to reduce coercion, targeting traditional religious healers, but also schools and the media as well. And what we're trying to do with Scope is to achieve earlier detection. So, well, to really sort of change the narrative a little bit. So a lot of the time we've been arguing that, and this is for sure unfinished business, that we need to expand access to care, yeah? But this is really saying there is some urgency about that the earlier the better. And that not only should we find people early, but we should really put a lot of effort into that first contact and that first period to really engage people and to get people on a better trajectory and optimize recovery in their own terms. So part of that, we've been doing, this is Desalen, I think, who's on the call. And Desalen's been doing some amazing ethnography with families, trying to understand what happens, partly to understand whether this construct of expressed emotions, which has sort of dominated the literature in family sort of interventions from the Western perspective, but how relevant is that for our setting? So we're hoping that will lead to family interventions. And we're also doing work around sort of developing a measure of recovery that will capture these aspects of restoring a person's life. And we're expanding from what we've done previously, not just in the rural areas, but now in Addis and also homeless populations. And just to say a quick aside, so Ababao did an important study in Addis looking and showed that 2 out of 5 people who were street homeless had a severe mental health condition, and that they were very excluded from existing services. So in Addis, where there's plenty of resources really, but just systematically excluded and very limited social support. And as you might expect, 80% of people that were interviewed had basic needs, concerns around food, obviously around shelter, water, sanitation, but also very highly prioritized with social needs for sort of interaction with other people, with relationships, and also physical health needs. And 40% sort of were living in sort of fear of being attacked, a sort of hostile environment. So we've sort of really, I've talked about how in RISE we were interested to think about what about the people who don't, get well, and we've after sort of a more simple intervention like a task shared model in primary care. So we've shown that adding CBR on can add something, an address for some people, but there's still a group of people who may be homeless or abandoned or restrained in holy water sites or imprisoned, and people with complex needs. And the field has not really been grappling with what to do and how to respond in an adequate way. So as I say, we've got a little bit of work going on in the Scope project on that, but we've got a whole focus on that in a new NIHR Global Health Research Group. And we're working in Ethiopia, Ghana and Kenya. I'm co-PI with Atalay, and we have Victoria Mutiso and David Endetai from Kenya, and we have Phyllis Dakogyeki and Peter Yarrow from Ghana. So what we're going to be doing is trying to extend the participatory action research to an even more challenging group, people with lived experience who've had experience of homelessness as well as severe mental illness. And we obviously anticipate that requires a lot of intensive investment to make that more than tokenistic. But on the other hand, we also feel that could be really the crucial way to approach this. So that's in process. So just to sum up with everything, I've been talking about expanding access to mental health care in sort of rural settings in Ethiopia, and I'm concluding that it's safe, effective, and cost-effective, and it has impacts that surprisingly go way beyond the biomedical, actually fairly biomedical intervention. So on the Allen Index, I think we might have to say that it should be scaled up. But on the other hand, I think there are some really key areas where restoring the person's life needs something more, something different. And as I've said, I think there can be a really unique contribution of thinking of how people with lived experience can be involved in that. And by empowerment, I don't sort of mean in a just kind of, I mean in a very sort of support, increasing people's capacity in their support, but also structurally and economically. And I think there is a really pressing need to evaluate economic interventions alongside our mental health interventions as well. And there's been very little done in that area. I mean, there's lots of programmatic work, but not much sort of in terms of trials. And then, as I've tried to sort of highlight, there's still a group of people with very complex needs who really probably do need some level of specialist mental health care and other things that are complicated and expensive, like housing. And how do we get a model of that could be workable in our settings? And so that's the focus. So here's a life in logos and a life in acknowledgements. And there we are. Thank you.
Good afternoon, everybody. It's my job to field the questions. Is this thing on? Okay, there we go. Good afternoon, everybody. Charlotte, thank you so much. What a wonderful, informative presentation. It's my job to field the questions. I'm Ashraf, Kat's Stellenbosch University counterpart. Are there any questions so far? Okay.
Thank you, Charlotte. That was a really lovely presentation. My question around, you mentioned on the slide last time there was some group that announced sexual action. So my question is, how does that actually look in Ethiopia? What does it mean? So we had, am I still on? Okay, yeah. Sorry. Great, thanks. So we had community advisory boards set up in the district, and that involved people from, for example, the police, NGOs who were mostly working on sort of livelihoods, and traditional religious healers, different sort of sectors, and not just the health administration, but the local government administration. So at that level, there was some kind of, that's where there was a mobilised response to people who were homeless, for example. That came through that committee, but that was established for Prime. That doesn't really exist. There are sort of, at the level of the health extension worker, their role is meant to be a liaison person, but they find it, I think, incredibly difficult to achieve that role. So I think, as in your work, Carrie, we found that it's difficult to get people to work across sectors. So, yeah. And perhaps, you know, maybe this is where sort of peer support, case management, or sort of help supporting people to kind of navigate and overcome those sort of inclusion barriers where there are resources, but they're just not being accessed.
So, for example, around livelihoods, I said about economic interventions, but maybe it's a social inclusion intervention actually in the first place, because there are quite a lot of livelihoods interventions in Ethiopia. But it just seems that people with severe mental health conditions and their families are systematically excluded from those. So maybe it's actually an easier win would be the social inclusion, maybe.
There's a question from Dan.
Thanks so much, Charlotte. It was great. Just two questions. One is, thanks. Thanks so much. Just one question is really about pharmacotherapy and the role of that in treatment refractory patients and how that all works in Ethiopia. I'm thinking in particular about clozapine and lithium and other kinds of augmenting therapies. And my second question is, if you're sitting in the UK, what are the lessons from this work? What can one take back or take to?
Great. So pharmacotherapy, there's no specific treatments for bipolar disorder that are available in the rural settings. So people with bipolar disorder are treated with first-generation antipsychotic medications. So lithium, although it's very excellent, is just the monitoring is problematic in the rural areas. So it's very cheap, but the testing is not cheap. So, I mean, I would argue that we need perhaps something like quetiapine on the essential medicines list. That would also be better for women with psychosis, with bipolar disorder. So the current alternatives are not really acceptable, or we're treating bipolar with first-generation antipsychotics. Clozapine is available in Addis in very restricted settings, but we've had significant supply issues. So I'm not even clear that it's available in the country at the moment. But while it was available, it was extremely helpful. But it's not the mainstay of what's happening in the rural areas. So we basically have chlorpromazine, haloperidol, and then amitriptyline, fluoxetine. Carbamazepine is used, obviously it's there for epilepsy, but it's used for bipolar disorder, but I don't think that's necessarily a good thing. Yeah, so I think there are some small things that could be done to improve. And people, we've had qualitative work where people have spoken, of how difficult it is to manage the side effects, especially the most available medication is chlorpromazine, and it is very sedating. And people sort of talk about balancing the need to work against the need to be well. And part of that sort of episodic engagement with care that we were seeing was that when people were well, they needed to work. And so they would stop medication because it was otherwise actually becoming an impediment to them achieving that higher level goal. What would I say in the UK? Well, I think, the UK has quite good integration of mental health in primary care, actually. So in terms of the sort of task sharing, in fact, Ababao says we should stop talking about task sharing. It's just integration of mental health into primary care, and it's what people do in good health systems that work. But I think the CBR component, which is a sort of very joined up, it's a bit more than a case manager. And I think potentially that is an important sort of role that could be used. And especially, peer support is obviously gaining currency world over. But I think, this idea of sort of structured recovery, helping people to navigate, but more than a case manager role in the UK, could be worth looking at.
Question?
Sorry, I think I can speak loud enough.
Okay.
Hi, thanks for that. Mariama. Very compelling results, and we wonder how much of this is care in the first place. And then my question is around the implementation side. If you can speak to maybe how do you foresee the scale-up, ultimately integration into the healthcare system, and ultimately access, because that is what we're seeing is that it's lack of access, right? In that direction, can you maybe speak to that?
Yeah.
How much of this is already part of the Ethiopian system? Thanks.
Thank you very much. So it's part of the strategy, but it's not really taken to scale. There's been quite a lot of sort of training of health workers in MHGAP sort of in isolation, but with not so much of those other kind of components of the integrated mental health care plan. I didn't really present much about the implementation science because I started putting those slides in and we would have been here till tomorrow. So I focused really on outcomes and not how to get to the outcomes in a sense. So I think it could be a long answer, but some very key, I think, again, a leverage point could be people with lived experience being more having a stronger voice to demand basically better care. I think when all other things fall apart and the systems, the system is more likely to be responsive to that than anything. And political commitment. So kind of really at the high level and at the low level, it needs both. And then we might get the middle people to do perhaps what they need to do. I mean, there's a lot more I could say. It's not just a kind of hit and run. It's a process. We're trying to establish something that's new. We're not sort of refining and improving something existing. So it's not a tweak to maternal care. This is something completely new. The health system is not set up for chronic care of any kind. It's all, set up for acute interactions with people. So there's not just the whole way that the data is collected in the health system, the way that consultations occur, the sort of power differentials between clinicians and patients. All of those things would need to be addressed to really more optimally deliver care, for sure. There was another component of your question that I missed. The first bit about whether any care is better. Yeah, I mean, I think, of course, I think a small amount of care can go a long way. And in a sense, I mean, you could say that really at the health centre level, probably when we analyse the kind of consultations, a lot of it was prescribing medication, and the psychoeducation was really about telling people to take medication. So that's not much, but somehow it achieved a lot more, and not on its own, but I think it kind of catalysed in people's minds that something could be done, and therefore people sort of regained a bit of motivation. So rather than having to put in sort of formal social services and formal this and formal that, the community actually solved problems that would really have been unsolvable if we tried to take a very formal sort of top-down thing. So maybe something small can catalyse something bigger.
Sharon.
Thank you so much. That was truly amazing. I have to read all those papers. I have two things I wanted to ask. The one was related to the substance abuse issue that you introduced in the earlier part, and then your very interesting new inquiry around the homelessness issue. And I wondered whether that's coming up there, either, where people become psychotic after substance abuse use or become homeless and then use substances as a comforting thing that leads to addiction. That was my one question. Then the other question, which relates, I suppose, to Carrie, is around the multi-sectoral issue. I wanted to ask you how strong the disability sector is in Ethiopia. Because for those 168 who don't recover, that picture looks like a disability, a psychosocial disability. And I wondered whether there's an opening, if there's any power there around the disability sector that people could be woven into that might also help open up other doors for them being included.
Great. Yeah, thank you very much. Just to take the second point first, we've had that idea as well. And one of the issues seems to be around language. So it's been very difficult to engage with that sector. So although CRPD talks about parity of physical and psychosocial disability, that is not at all strong. That, in fact, it's very strongly opposed within Ethiopia. So the disability organisation, it's very difficult to get psychosocial disability within. Eleni, our president of the Mental Health Service User Association, has been working really hard advocating for that. And it's partly, I think there is a linguistic issue that the term disability in Amharic kind of connotes something physical. So we probably need a better word, but it goes beyond that, and I think stigma is part of that probably. So I think it is where we need to act, and maybe that's where some of our social contact around sort of increasing inclusion could happen. Substance use and homelessness. So the PhD student Caroline, who's the new project manager on the HOPE group, her PhD was looking at pathways into homelessness and through homelessness. And comorbid substance use was part of the reason that people with severe mental health problems became homeless. I think it seemed to be more around that way round. There were some people with substance use problems who may have sort of experienced traumatic events and sort of triggered sort of development of a more severe mental health condition. And it's partly around, I think, social acceptability of substance use. You know, it made it, families absorbed so much from so many different issues and just really with the only kind of support there for the person. But the substance use seemed to just kind of push that beyond. So it is going to be a key focus for sure for the homeless work. Yeah, definitely. We've done it in Prime. There was a little bit of work around sort of brief detection and brief intervention for alcohol use disorders that showed some benefits, but it was very small scale. I think we need, but it excluded people with severe mental health conditions. So talking to the UK, of course, that would also be the case quite often, that these services get separated. So I think one of the things we have to do is make sure we don't do that and reinforce that. And just to say, sorry, with HOPE, we're also being a bit broader than psychosis for the homeless population because of ethics and just generally it seems a more pragmatic approach. So that will include adults with developmental disabilities or acquired brain injury, people with primary substance use disorders. There's a discussion about whether they're in or out, but you know, it's a slightly different question. It's a service question really, about what makes most sense, and it may be different in the different settings.
Thank you. I think we're out of time for questions, but thanks to everyone and special thanks to Charlotte. I think it's so wonderful to see the journey from the early research questions and how it was all identified in the gaps, and you guys just took it forward in a very difficult times and settings where you are collecting amazing data at very high quality. So special thank you to you from all of us. And thanks to everyone here for coming. I think it's always my favorite time of year when we do the Ellen J. Flisher Memorial Lecture. And of course, of those joining online, you did get to hear the presentation from Atalay, but I will again send it to everyone in the room today. So thanks again, and we'll see you next time. Thanks.